As we talk about spondylopathies, we are going to group together two types of spondylopathies, spondylolysis and spondylolisthesis. These are a genetic congenital weakness in the pars interarticularis, which is between the superior and inferior facets, that can predispose this structure to a stress fracture. It often does not manifest itself until the patient is active. The cause may be traced to hypermobility of the spine, disease state, or acute trauma. Again, it is a stress reaction that leads to a fracture, and it is the most prevalent bony injury to the spine in athletes. It commonly occurs at the L4, L5, or L5S1 levels. Spondylolysis is a defect in the pars interarticularis, the area of the vertebral arch between the inferior and superior articular facets, usually done by repetitive stress. The patient is going to present with localized low back pain that is increased during and after activity. During observation, spinal alignment is usually normal. Active range of motion is normal for flexion, but pain restricts extension. Spondylolysis may progress to spondylolisthesis. In this case, the defects in both elements of the pars interarticularis results in the separation of the vertebral into two uniquely identifiable structures. Basically, we have a bilateral spondylolysis going on here. Fixation between the affected vertebral and the one below it is lost, resulting in the superior vertebrae sliding anteriorly and possibly inferior onto the one below it. In spondylolisthesis, the true healing of the fracture site rarely occurs. It is most prevalent in adolescents and in women. Young gymnasts have an incidence of pars interarticularis defects 4 times higher than that of the average population. However, we will also see it in weightlifters and football linemen, secondary to repetitive flexion, hyperextension loading forces that are inherent to their sports. Pain associated with spondylolysis and early stages of spondylolisthesis tend not to radiate. There is a grading of spondylolisthesis based on the extent of subluxation, graded stages 1 to stage 5. You can see here that in stage 1 and 2, we have up to a 50% subluxation. In stage 1 and stage 2, the athlete may continue with activity as long as pain and symptoms allow. In stage 3, it often requires removal from activity and surgical management for stabilization, which obviously also be required for stages 4 and stage 5. The mechanism for both of these conditions includes a current thought that suggests that the pars interarticularis suffers a stress fracture secondary to repetitive stress caused by the spines going into extension. The pain is insidious and often begins as an ache and evolves to constant pain. Pain characteristics include pain in the lumbar spine that possibly radiates into the buttocks and upper portion of the posterior lateral thighs. Intensity of the pain increases as the condition worsens, and the pain increases with hyperextension. Predisposing conditions include imbalances in trunk muscular strength, endurance, and flexibility. We will also see that it is more likely to be in activities that repetitively place the lumbar spine into hyperextension. Females have a higher incident rate than males. Gross inspection of the spinal curvatures may reveal hyperlordosis in lumbar spine. The patient may also walk with short stride and remain stiff-legged. A palpable step-off deformity may be detected at the involved lumbar level. There may also be possible spasm of the paraspinal muscles. Active range of motion during trunk flexion is restricted but pain-free. The patient will have pain as they are returning to the upright posture and during active extension of the spine. Pain may also be elicited during lumbar spine rotation and lateral rotation. During passive range of motion, hip flexion may indicate tightness of the hamstring muscles. With resisted range of motion, we will look for weakness of the spinal erector muscles. Other things that we might consider or look for include tightness of the hamstring or weakness of the abdominal muscles. Spring tests may reveal pain. A lower quarter screen will be used to rule out involvement of one or more lumbar nerve roots. A single leg stance or a straight leg raise may produce pain that is worse than the normally caused by tightness of the hamstring group. A stork standing test may also be used. During radiographic examination, a CT scan or MRI is required to differentiate between spondylolysis and spondylolisthesis. In spondylolysis, there will just be a stress fracture, whereas with spondylolisthesis, we will actually see slippage of the superior vertebra on the one below it.